This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Shuvro Roy from Johns Hopkins University with today's Neurology podcast. Today, we're fortunate enough to be joined by Matilde Inglese from the University of Genoa to talk about a topic that's actually a blind spot for most clinicians, which is the use of stem cell transplantation in multiple sclerosis. Matilde's work was recently published in Neurology titled Hematopoietic Stem Cell Transplantation in People with Active Secondary Progressive Multiple Sclerosis. Transplantation has classically been managed by hematology and oncology transplant experts, and the management of neuroimmunologic conditions has fallen into the purview of neurologists. As a result, it's a bit of a challenge to find a home for this sort of treatment, and particularly for this indication. So, Matilde, we're so grateful to have you join us.
Thank you, Shuvro.
I think the first thing to start with is really outlining the scope of the issue. And so I was wondering if you could take us through the current treatment landscape for patients with active secondary progressive MS.
Treatment landscape for patients with active secondary progressive multiple sclerosis has evolved significantly over the past few years, especially in the US, where several disease-modifying treatments such as siponimod or cladribine, ofatumumab, or ponsimod have been approved for relapse onset multiple sclerosis, including secondary progressive multiple sclerosis. In Europe, and especially in Italy, the situation is slightly different because only siponimod has actually been approved for secondary progressive multiple sclerosis. Although the landscape has evolved significantly for secondary progressive multiple sclerosis, we all know that these patients, the efficacy of treatments in reduction of disability worsening is modest. And what it is still unclear is that whether the effect of treatment persists over time. For instance, in the EXPAND trial, after 2 years of treatment with siponimod, the average delay of disability was only 19 days per year. So a small benefit after all.
I think it's important to establish that hematopoietic stem cell transplant itself doesn't necessarily have a direct therapeutic effect on the nervous system, but rather, as I understand it, the goal of the procedure is to ablate and reset the immune system. What is our understanding of how stem cell transplant might work in the treatment of MS?
The intense immunosuppression followed by autologous hematopoietic stem cell transplantation has been increasingly explored as treatment strategy for aggressive multiple sclerosis. And the rationale behind the treatment is to eliminate self-reacting cell clones, induce self-tolerance through a profound renewal of the immune system. And there are several biological mechanisms that are thought to be responsible for the resetting of aberrantly overactive immune response in multiple sclerosis. And some of these mechanisms, for example, includes the normalizations of the restricted T cell repertoire, both in the peripheral blood and in the CSF, or the selective reduction of the encephalotogenic effector response, the increase of immunoregulatory cell subsets, and the reduction of pathogenic memory cells within the bone marrow niche, all of which are thought to drive chronic inflammation.
That's so fascinating, especially with regards to just understanding that we're looking at several different targets to target not just active inflammation, but perhaps the compartmentalized inflammation that we know may be driving progression independent of relapse. I was wondering if you could take us through the design of the study. How did you identify your patient population, and what were your endpoints here?
Our study was a retrospective observational study, and the aim of this cohort study was to compare the effect of hematopoietic stem cell transplantation on disability outcomes in people with active secondary progressive multiple sclerosis in comparison to patients with active secondary progressive multiple sclerosis under other approved immunotherapies. And we collected data from the Italian bone marrow transplantations in multiple sclerosis register and from the Italian multiple sclerosis register. So the hypothesis was that patients with active secondary progressive multiple sclerosis have better disability outcomes when treated with hematopoietic stem cell transplantation than with other approved DMTs. And the primary objective of our study was to compare the proportion of patients with a 6 months confirmed disability progression in the two treatment groups. And as by convention, disability progressions was defined as an increase of 1 point in the EDSS score or 0.5 points if the baseline EDSS score was equal or greater than 5.5.
And what did you find?
Time to first confirmed disability progression was significantly longer in transplanted patients, with 61.7% of transplanted patients free from disability progression at 5 years. And patients who underwent transplantation were also more likely to experience a sustained disability improvement. So 34.7% of transplanted patients maintained an improvement, that means a lower EDSS than baseline, 3 years after transplant, versus a percentage of 4.6% of patients that maintained an improvement in the treatment arm with other disease-modifying treatment. So it was a very surprising positive finding.
It was striking to see how in the stem cell transplant cohort that the average EDSS change per year was actually slightly negative, while it was obviously, as you mentioned, positive in the DMT cohort. And even when you adjust for the high efficacy therapies versus the lower efficacy therapies, those findings continued to persist. And what do you think accounts for those differences?
So despite the treatment with the most of the available anti-inflammatory treatments, because the control active secondary progressive multiple sclerosis group was under treatment with several anti-inflammatory disease-modifying treatments, beta interferons, glatiramer acetate, azathioprine, mitoxantrone, fingolimod, natalizumab, methotrexate, teriflunomide, cyclophosphamide, dimethyl fumarate. And the only drugs that was not included was ocrelizumab. And despite this, the control group exhibited a mean disability accumulation of 0.16 EDSS point per year and rate of confirmed disability progression in line with those reported in other studies on secondary progressive multiple sclerosis. Conversely, as you mentioned, in transplanted patients, we observed a stable EDSS time course over time with slightly negative changes. So I think that our results show that treatment with hematopoietic stem cell transplantation in early active secondary progressive multiple sclerosis has the potential to slow down and in some cases to reverse neurological disability. What do I think account for these differences? I can only speculate on this. And so what we think is that although the mechanisms underlying CNS repair are not completely understood, it is well known that one of the biggest challenges for recovery is the presence of a chronic inflamed microenvironment that impairs remyelinations and neuronal plasticity, which this chronic inflammatory microenvironment could be potentially targeted by the CNS penetrant chemotherapy that is used during hematopoietic stem cell transplantation.
I think that's a really valuable point. This idea of this chronically inflamed, compartmentalized inflammation that unfortunately most of our drugs cannot reach is really, I think, the next target. And how do we manage patients with MS and particularly those with progressive disease? It seems that this is an excellent treatment modality for patients with early disease and early active secondary progressive disease. And I can't help but think about some of the signals that we've seen, even in primary progressive disease, where we've seen that the benefit of ocrelizumab doesn't seem to be as clear for patients who are, say, older than 55. I guess in this case, do you think there are any patients with secondary progressive disease who might not be a good candidate for hematopoietic stem cell transplantation, whether it is older patients or patients who have more progressive disease? Who are the best candidates in your mind?
We have previously reported that superimposed relapses and inflammatory activity at baseline MRI are favorable predictors of a better outcome after hematopoietic stem cell transplantation in MS patients in general, in patients with secondary progressive MS specifically. So younger age and shorter disease duration at transplant are other well-known favorable predictors of better outcome after transplantation. Therefore, the best candidates for hematopoietic stem cell transplantation are young patients with early active secondary progressive multiple sclerosis. So it is important to note that the results of this study might not be applicable to older patients with secondary progressive multiple sclerosis without signs of inflammatory disease activity, either superimposed clinical relapses or MRI activity.
I think that's valuable information, especially as clinicians consider who they should be considering for this therapy, which I think we'll cover more in a few minutes, because I'm really quite curious as to what you think and how you would go about choosing a patient for a stem cell transplantation. But I think one of the other things, especially that's a blind spot for many of us as neurologists, is the idea of the appropriate conditioning regimen for a stem cell transplant. And I know there are a variety of different conditioning regimens, meaning the chemotherapeutic agents that are given to ablate the immune system before the stem cell transplant itself. In this case, you went with the BEAM protocol, which in existing studies seems to have the best efficacy, but perhaps is the most intensive, perhaps the most myeloablative. What are your thoughts on the appropriate conditioning regimens, or can you educate us on the different conditioning regimens available before a stem cell transplant?
Yeah, this is a very good point, because the optimal intensity of the conditioning regimen for hematopoietic stem cell transplantation in multiple sclerosis remains unknown. It's actually a hot topic, and there is a lot of controversy around this topic. So the intermediate intensity conditioning regimens using cyclophosphamide and anti-thymocyte globulin that are purely lymphoablative, and BEAM plus anti-thymocyte globulin that are, as you mentioned, myeloablative, are the most widely used conditioning regimens, with both demonstrating promising efficacy and both suggested as the most useful options by the European blood and bone marrow transplantation. In Italy, in one Italian court, the use of myeloablative BEAM conditioning regimens was independently associated with reduced probability of relapses, MRI activity, NADA3 failure in patients with relapsing remitting multiple sclerosis. But there are still controversies. I think that another important point is to note that there are other factors, such as the cyclophosphamide used during the mobilization of stem cells and the anti-thymocyte globulin, and these other factors may play a role in determining the overall intensity of the procedures as well.
I thought it was interesting that you were able to conduct this study, even with obviously retrospectively, without MRI data available in some patients. And so the reason I'm interested in that is it's obviously a data point that we use quite frequently in the evaluation of patients and particularly their disease modifying therapies and when to change therapies or escalate therapies. But I was really curious if you could take us through your approach for choosing a patient for hematopoietic stem cell transplantation. Would you base it on their disease activity? Do you base it on clinical relapses, MRI activity, the failure of a prior DMT? How do you decide to go down this route?
It is important to make clear that all the transplanted patients included in the studies were treated according to the European Group for Blood and Bone Marrow Transplantations guidelines. So, following the decision of the treating physician and the approval of the local ethical committee. The MRI was performed in all transplanted patients because it's very important to judge the severity and the disease activity. So it was performed in all transplanted patients for screening before the procedures and during the follow-up. But for few of them, I think 6, if I remember correctly, the official MRI reports at baseline was not available at the time of the retrospective data collection performed in this study. But the ideal candidate for the hematopoietic stem cell transplantation has been recently described by the European Bone Marrow Transplantation Group. And, for example, the ideal candidate in patients with relapsing remitting multiple sclerosis are patients with at least 2 clinical relapses in the previous year or 1 clinical relapse with concomitant MRI activity under highly effective, high efficacy disease-modifying treatment with an EDSS equal or less than 5.5 and disease duration less than 10 years. This is for relapsing remitting patients. Ideal candidate within the secondary progressive MS group are patients with the clinical progression in the last 12 months, only when inflammatory activity is still evident, either as superimposed the clinical relapses or as MRI activity.
That's very helpful, and I think very clearly outlines actually what patients we should be considering for the therapy. And as we've discussed, the use of stem cell transplant may help address the smoldering inflammation behind the blood-brain barrier that we theorize drives much of progression independent of relapse. From what you just said, it sounds as though this may be an option, certainly for patients who have phenotypes beyond secondary progressive disease.
We know that progression independent of relapse activity, which occurs in relapse and MRI activity-free patient, is emerging as one of the main drivers of disability progression in all phases of multiple sclerosis. And so a shift away from simply targeting relapses and focal MRI activity is needed, and the focus of attention has to be redirected to halting the processes responsible for smoldering multiple sclerosis. So I think that as our knowledge about the mechanism underlying progression independent of relapse activity increases, and as long as we become able to identify biomarkers of progression independent of relapse activity, biomarkers of smoldering multiple sclerosis, the hematopoietic stem cell transplantation might play a role in all MS patients. But I think we need to increase our knowledge on and develop biomarkers, reproducible and robust biomarkers of smoldering and progression independent of relapse in multiple sclerosis. But bone marrow transplantation might become an option in all MS patients.
Finally, if a patient were to be interested in trying to pursue this sort of therapy, obviously we know that these aren't readily available, and that especially for this indication has not been approved yet. And so I guess what, if any, counseling would you have for a patient in safely choosing a center to pursue transplant, and when should they really consider it?
Both the National Multiple Sclerosis Society in the US and the European Bone Marrow Transplantation Group in Europe have published guidelines where patients are recommended to be treated only by specialized centers with experience and expertise in both MS treatment, MS care, and cell transplantation. This is extremely important because the center experience in treatment of autoimmune diseases results in a statistical significant improvement of overall survival, including disability-free survival and transplant-related mortality. So this is very important to be referred to centers with experience and expertise in the procedures. In addition, there are several prospective clinical trials that are ongoing worldwide in the US, in the UK, in Norway and Sweden, so in North Europe, and in Italy. And patients should be referred to those centers involved in such clinical trials as well.
I really appreciate you taking us through such a wide spectrum of understanding the utility as well as even just the logistics of stem cell transplantation, particularly for patients with multiple sclerosis. Once again, if you would like to read the full results of Matilde's work published in Neurology titled Hematopoietic Stem Cell Transplantation in People with Active Secondary Progressive Multiple Sclerosis, you can certainly do so, and I certainly encourage you to do so. Matilde, thank you again so much for joining us.
Thank you very much. It was a pleasure to have this conversation.
This is Stacey Clardy, your podcast editor. Thank you for listening and for letting us join you on your commute, while you're exercising, or even while you're brushing your teeth. This has been another episode of the Neurology Podcast, your best source of practical, relevant, and timely information for neurologists, clinicians, and patients. The views and opinions of the participants in this podcast do not necessarily reflect those of the journal Neurology or the AAN. Disclosures of the participants are included in the show descriptions, reached by a link on the neurology.org website.